So there will be clinical relations mostly already mentioned in the lectures. So there will be not too much new in today's lecture. I would like to focus on things that can be possible questions also in the final exam. And especially I will show you pictures where what can be asked, for example. But most of the things I mentioned today were mentioned in the practice or in the lectures. So let's start with some histology slides. So for example, if you get the spinal cord slide, then not only the spinal cord structure you have to talk about, but you will be getting questions about the pathways in the white matter, which pathway is running where, and then one syndrome, which I indicated with exclamation points in the lecture too. One syndrome will be asked by name. This is the Brown-Zechar syndrome. When we talked about the descending pathways of the spinal cord, I also mentioned that this is something you do have to know. And this is the prototype of a half lesion, a hemilesion of the spinal cord. Of course, it's very rare that exactly in the midline is the lesion, but it's still the prototype. So when something is compressing it from the outside, or there is an injury, like in this case, backstabbing, then this is the prototype of the injury, or this case is a hernia compressing the spinal cord from the side. So this you do have to know what are the symptoms. And when you did the pathways, you did, we did it together, that which sensory tracts and which motor tracts are running in the spinal cord and in which part. So there is ipsilateral paralysis. Why? Because the corticospinal tract, which supplies the extremities, the lateral corticospinal tract, is already crossed in the medulla. So these are already the crossed fibers innervating the same side. So there will be ipsilateral loss of motor functions. About the sensory, we learned the two main pathways, two main conscious pathways, the spinothalamic tract surrounding the anterior horn. So it's running in the lateral and anterior cords, and it is already crossed. So in the spinal cord, it's a crossed pathway because it crosses shortly after entering the spinal cord. So there will be contralateral loss of protopathic sensibility, pain, temperature, and crude touch. And the dorsal column will run ipsilateral in the spinal cord, will go to the nucleus gracilis and only cross after. So it means that in the spinal cord, it is still an ipsilateral pathway. So there will be ipsilateral loss of vibration and fine touch, so epicritic sensibility. This is the Brown-Zechar syndrome. Still staying at the spinal cord, here in the motor neuron part, you can mention the ALS, which is usually a very sad disease because patients usually die within a few years after diagnosis. The amyotrophic lateral sclerosis, which means it is a motor neuron degeneration. Only the motor neurons degenerate in the spinal cord and in the brainstem. These patients usually lose all motor functions, which means also in the face. So they cannot chew, they cannot eat, they cannot talk, they cannot use any facial expression. Usually what is left is the eye movement. Somehow the eye motor nuclei are spared most of the times. And of course, the most famous such patient is Stephen Hawking, who died a few years ago, and he could communicate only with his eye movements. If you have time, look at the movie, watch the movie based on his life. It's very interesting and very well showing this disease, the ALS, amyotrophic lateral sclerosis. Then still staying with histology, here, for example, you get any central nervous system slide. We can ask you about glial cells. We will ask you about glial cells. Not only when you get the astrocyte slide, But with any other slide, cortex, cerebellum, spinal cord, we can ask you what type of glial cells do you know. Usually people can list very well oligodendrocytes, astrocytes, microglial cells, ependyma cells, and then the special glial cells. And here with the oligodendrocytes, there is one disease you should know because it's a very common, unfortunately, a very common disease, the multiple sclerosis. It's also called the disease with 1,000 faces because it affects, of course, the symptoms depend on which tracts are affected. It doesn't always start in the same place at all. It many times affects long pathways, and the symptoms depend on where the disease is happening, where the demyelination is happening. So in this disease, the cells, the neurons lose their myelin sheath. So that's why it's called a demyelination disease. They lose their myelin sheath. Many, many times it starts in the optic nerve and optic tract. So patients have visual problem, usually on one side. And many times it's like when the disease first starts, it can be the first symptom, but then it goes away, and years later, another attack is coming. And patients many times do not even care about this first symptom because then they see well. And only when the second attack is coming, they think back, yes, a few years ago, I already had a similar problem. And you see it affects these long pathways, dorsal column many times, which leads to ataxic gait problems, cerebellar tracts, the medial longitudinal fascicle, which coordinates the eye movement. So there are eye movement problems. So there are many different symptoms depending on which pathway is affected. So you should know the name of this disease. Still staying with histology, there is this slide where there is not too much to show. In the slide, the motor end plate slide with the skeletal muscle and the motor nerves. Here, I mentioned one disease which affects the receptors, the Myasthenia Gravis. If you don't know the name, it's fine. This won't be asked from everyone, of course, but for a better grade, you can mention this disease. It's an autoimmune disease when we have antibodies against the acetylcholine receptors. Acetylcholine receptors are in the postsynaptic membrane, and acetylcholine is released. This is the transmitter in the motor end plates, the neuromuscular junctions. And it's very interesting. If you know anatomy, you can actually guess what is going to happen with these patients. Of course, weakness, tiredness is the leading symptom of the skeletal muscles, especially in the evening when you have already used your muscles, and especially in the muscles which you use the most. Which muscles are used the most? The eye muscles, eye movements, including the levator-palpebralis muscle. So a leading symptom is ptosis, dropping eyelid, and diplopia. Diplopia, this is again anatomy. You know that looking straight ahead, you need extra muscle function because the axis of the orbit is diverging. So when you relax all ocular muscles, you will have double vision because the eye muscles follow the axis of the orbit, which is 23 degrees outside. That's the diverging part of the orbit. So it means when you get tired, then you will have diplopia in this disease. Then facial expression, the larynx muscles, so patients have problem with speech, also swallowing. These are the muscles we use the most during the day, skeletal muscle. And of course, the whole body is tired and weak, especially at the evening. Okay, let's go to the brain and macroscopical pictures that you can be asked in the exam. For example, these are all from our previous lectures, basal ganglia. Here, if you get these sections of the brain, which are many times shown in the exam, not only when you get those 3 questions, frontal, horizontal, or sagittal brain sections, but this can be a body walk picture. And the substantia nigra is very well seen always because it's a black line because of the dopaminergic neurons that have neuromelanin. It looks black, so it's always a good and easy thing to use for orientation. So substantia nigra. Usually the next question is, what are the connections? And you mentioned the most important connection is the nigrostriatal tract going to the striatum. Is a very important connection of the basal ganglia. What is the transmitter there? It's dopamine. And which disease do you know associated with this nucleus? And then you have to know Parkinson's disease. Parkinson's disease is one of the most common neurodegenerative disease when exactly these dopaminergic neurons degenerate. And in this case, we don't have this connection. And you learned that dopamine is facilitating movements. It stimulates the direct and inhibits the indirect pathway. So that's why if you don't have this facilitating effect, the inhibitory effects are dominating. So there will be hypokinesia, which is one of the most leading symptoms of Parkinson's disease. Patients are very slow. They can't start a movement, or they can start it really hard, or end the movement, or change a movement. They walk very slowly with very small steps. So this hypokinesia is the most important sign, and it is associated with increased muscle tone, and patients have tremor as well. And of course, the logical replacement therapy is that you give dopamine in form of a precursor L-dopa, and this is how most of the drugs, most of the patients are handled. Details you learn in neurology and pharmacology later. Then I would like to talk about a little bit more about stroke. Why? Because stroke is the 3rd most common cause of death in Western countries. Here you can see the 3 most common causes: coronary heart disease, cancer, and stroke is the 3rd, and is the leading cause of chronic disability. So patients who survive the stroke attack, many of them have symptoms left, and that's the most common cause of chronic disability. It affects 15 million people a year. So it's a very, very common problem. And it's actually a summary of different things happening. People usually think of bleeding at first, but bleeding accounts only for about 20% of stroke cases when we have a bleeding in the brain. Usually it's an ischemic stroke, so there is an occlusion of a vessel by thrombosis or emboli. And here you can see there are different, you don't have to know this, of course, the exact types of stroke, just ischemic and hemorrhagic or bleeding. And we learned about these vessels here, these small vessels supplying the area of the internal capsule, the putamen, pallidum, thalamus, and caudate nucleus. So this whole area is supplied by the little thalamostriate and lenticulostriate arteries. And here the hemodynamic situation is really, really unfavorable because we have a big vessel, the middle cerebral artery, giving off small blood vessels. So there is a very sudden change of diameter, and they are going perpendicular. So even the course is very unfavorable. So these are favorite places for embolies to get stuck. And for example, knowing anatomy will help you so much later as well, because you can follow the course of an emboli if you know the blood supply. And embolism many times happens in the left atrium, for example, if somebody has a rhythm problem, like the heart is beating arrhythmia and fibrillation, and especially in the atrium, the left atrium, where it's kind of a closed section of the heart, there can be a thrombus formed, a blood clot, which can get loose. It goes from the left atrium to the left ventricle to the aorta, and from the aorta it goes to one of the brain vessels, and then it gets stuck here. And then it causes an ischemic stroke. And here we have so many things, especially in the internal capsule, all those pathways running. The patient will have big problems. That's why people with this rhythm problem, they have to take anticoagulant therapy to avoid this from happening. And it's a special type. Maybe you have already heard about it. You don't have to know this. I'm just showing it as an interesting thing, and you will, of course, learn it very detailed later in neurology. The transient ischemic attack, TIA, when the symptoms last no longer than 24 hours. So these are very small thrombus or embolism. You can have many at one time in different places, and you can have, of course, many different symptoms depending on where the problem is. Motor signs, weakness, half of the body or just part of the body is paralyzed, sensory loss, visual problems, speech problem, dizziness, balance problems, consciousness problems, so anything depending on where the location is. And people who have risk factors, they can have it several times coming back, these attacks, and they are really, it's a high risk that they get a big stroke when they had several of these smaller attacks. The signs, after learning neuroanatomy, the symptoms you can easily collect, actually, depending on the location. I'm not going to read this, just focusing on some things, of course, depending on where you have the lesion, and you know which brain center is there, which pathways run there, you can collect the symptoms. Here, I show you exam situations where these things can be asked. For example, I already mentioned this area, which is supplied by the thalamus striate and lenticular striate arteries. Here, there is the internal capsule, very nice, anterior limb, genu, posterior limb, and then you have the acoustic and the optic radiations. Here, this picture is shown also many times, or a similar picture is shown many times in the body walk, where we can ask the basal ganglia, thalamus, the radiations, etc., and the internal capsule. It's asked many, many times, what is this? Which part of the internal capsule is it? What tracts are running here? And the pyramidal tract, we know, is running in the genu. The genu is the corticonuclear tract, and then the rest of the pyramidal system, the corticospinal, is running in the posterior limb, first upper limb, then lower limb. So we have a nice somatotopic organization. And the pyramidal tract, we can also ask, of course, in these pictures, this is the pyramid, this is the decussation, where the corticospinal tract fibers decussate. And these are the pictures from my lecture, and I drew your attention then to that this, you have to know what it means, peripheral and central paralysis. And peripheral is when the motoneuron is damaged. So we have a motoneuron and the outgoing nerve. This is a peripheral lesion. This is with decreased muscle tone. The central paralysis leads to spastic palsy, which means increased muscle tone. This is anywhere, the descending pathway affected anywhere above the motoneuron, so in the cortex, in the internal capsule, in the brainstem, the pyramids, anywhere before it reaches the motoneuron, leads to a central palsy. And we talked about the corticonuclear tract. This is also just revision of what we did in the lecture previously. Corticonuclear part of the pyramidal tract is the part that innervates the motor neurons in the nuclei, the motor nerve nuclei. And I drew your attention then too to the fact that most nuclei receive bilateral innervation, which means that from one descending pathway, both sides will be supplied, which means that if one descending pathway is damaged, you won't have any symptoms or very little symptoms maybe, because this nucleus is supplied also from the other side. So the other side can compensate. And that's why you have to know the exceptions. This is what we do ask in the exam. Which are the motor nuclei that receive only unilateral innervation? And this is always contralateral. Why is it like this? I don't know. But these are the exceptions. The lower facial muscles, the genioglossus by the hypoglossus nerve, and the uvula from the vagus area. So these are the muscles that are getting only unilateral innervation. And then, of course, the lesion of the pathway of the corticonuclear tract will lead to palsy. And again, just drawing your attention to supranuclear and peripheral lesions. So these pictures, again, this favorite horizontal cut corticonuclear tract is running in the genu. And here you can also see a lot of nerves can be asked and pathways in these pictures too. Let's talk about the facial nerve because this is the most common nerve lesion, cranial nerve lesion, more common than all the others together. And both are common, the central and the peripheral lesions are also common. And here, these are the pictures I showed you also in the lecture. So the upper muscles around the eye and forehead, the upper muscles get bilateral innervation, which means that in a central palsy, only the lower muscles will be damaged or will be paralyzed. The upper muscles will stay intact. In the peripheral lesion, of course, depending on the exact site of the lesion, all the muscles on that side will be paralyzed. Like in this picture, here you can see this patient cannot move anything on this side because of an acoustic neuronoma compressing the facial nerve. And plus, now you know we learned a lot of other things the facial nerve does, not only the muscles of facial expression, but has taste fibers through the chorda tympani. The anterior 2/3 of the tongue get the taste innervation from the chorda tympani. This will be lost on that side, of course. Then you will have loss of tear secretion on that side because of the greater petrosal nerve, which gives the innervation for the pterygopalatine ganglion and then to the lacrimal gland. And it's not a facial expression muscle, but belongs to that group, the stapedius muscle in the middle ear, which is also innervated by the facial nerve, which protects the inner ear from sudden, strong noises. And this will be also lost. So, and these patients complain about hyperacusis. For example, talking on the phone can be really disturbing because they hear it too loud, too bothering. And this is also anatomy, that you know which fibers have thick and which have thinner myelin sheath. You know that the motor nerves always have the thickest myelin sheath, and the sensory nerves have thinner myelin sheath. So here, many times, the taste will be lost first. I know several people who had facial nerve palsy, and that's how it started, that they couldn't taste the food. Of course, you could say, yeah, but the other side of the tongue and the back of the tongue is still okay. Yes, but you still notice if half of the tongue taste is gone, you notice it. And many times, chorda tympani is the first nerve affected in a peripheral palsy. In central, you don't have these, because the central, the corticonuclear tract, only affects the muscle, not the other functions. And these are the pictures where you can ask a facial nerve. Very, very important. There are many, many pictures and many areas where we can ask the facial nerve. Here, for example, a dissected face, you can see how the branches come out from the parotid gland, all the muscles where we can ask, what is it? What is the nerve? What do you know about peripheral facial nerve palsy? Or these pictures where you can see the exit of the cranial nerves, or middle ear pictures where you can see always how the facial canal is running around the middle ear, the tympanic cavity. There can be any question coming up with the facial nerve, or these things where again you can see the exit of the facial nerve in the pontocerebellar angle, or in the rhomboid fossa, where you can see the facial colliculus, which we know that is not the nucleus of the facial nerve, but of the abducent nerve. But the facial nerve, before exiting, makes a hook, a loop around the abducent nucleus, and this is what makes the colliculus. And so here, with all these pictures, we can ask you questions about the facial nerve palsy. These pictures here show half peripheral palsy in every case. Here you can see that this patient couldn't even close the eyes. Facial nerve closes the eye, because facial nerve innervates the orbicularis oculi muscle with which you close your eyes. So this is a common mistake, that they say patient cannot open the eyes. No, the opposite. Patients cannot close the eyes, and this can be with the decreased tear secretion, it can be a big problem for the eye. And this patient is, after treatment, regenerated. The other nerve, if we go back to this picture that I showed you, very important to know which cranial nerves get only unilateral innervation. So facial nerve lower muscles, genioglossus, and the uvula. So here, another very important topic is the vagus nerve. Vagus nerve can be asked by the help of any of these pictures showing the neck, what we did this semester, where the facial nerve is running in the carotid sheath, etc. And all these branches, especially the laryngeal branches, are asked many, many times with the superior laryngeal and the recurrent laryngeal nerves. Here you can also, if you get a picture like this or around the aorta, you can see how the recurrent laryngeal nerve is going back, and then it runs in the scalenotracheal fossa. These pictures showing anything from the larynx, we can ask you branches of the facial nerve, where it crosses the inferior thyroid artery. So there are many places where you can get a question about the vagus nerve. And the superior laryngeal nerve, you know, this is it, which innervates with the extrinsic branch, the cricothyroid muscle, and with the intrinsic branch, it gives sensory innervation for the area above the vocal fold. So if this nerve is lesioned, it can also happen in thyroid surgery, for example. Then the cricothyroid muscle will be lost, will be paralyzed, so the tone of the voice can change, and the protective reflex is lost. What do I mean by this? The upper part of the larynx is which receives, if the fluid goes the wrong way, or any particle, any foreign body, then you immediately start coughing and you try to get rid of it, because the upper part of the larynx senses it immediately. And this protective reflex can be lost, so it's easier to get aspiration to get foreign bodies into your deeper part in the larynx and then in the trachea. The recurrent laryngeal nerve, which is many times lesioned, unfortunately, during thyroid surgery, for example, or any other neck surgery, then all intrinsic muscles will be paralyzed on that side, of course, There will be asymmetry of the vocal ligament, hoarseness of the voice. The uvula is more of diagnostic importance because in the central lesion, this is the muscle that receives only unilateral innervation, so there will be an asymmetry of the uvula. It will be pulled towards the intact side. And the last such muscle is the genioglossus muscle, which sticks the tongue out. It receives only contralateral fibers. So you can see that there is an asymmetric position of the tongue. If it's chronic, then even the muscle can atrophy. Let's see some other localizations. These are also pictures from my earlier lectures, so you don't have to know this. I told you there that this is only for demonstration. You don't have to know the name of this disease. You will learn it in neurology, but I wanted to show you that even a part of the medulla where we have a lot of nuclei and a lot of pathways supplied by the pica, posterior inferior cerebellar artery, if there is a damage here, thrombus or an emboli, then this area of the medulla will be gone, and there is a complex syndrome because there are many things here, vestibular nuclei, for example, so the patient will have dizziness, balance, the cerebellar peduncle is there, sensory pathways running there, the sympathetic pathways running there, so there will be many things, many symptoms. Here I show you a case with middle cerebral artery occlusion. These are all risk factors: hypertension, age, hypertension, hypercholesterolemia, and coronary bypass surgery. This patient had a 1-hour history of dysarthria. Dysarthria means you can't speak clearly, you have speech difficulty, and because of the muscles. And there is a right gaze tendency. You just learned it when you did the regulation of eye movements, that if the descending pathway going to the eye muscle nuclei is damaged, then you have a gaze tendency. And the patient has facial droop, so around the muscles of the lip, and Babinski reflex, extensor plantar response. And then with CT scan, it was revealed that he had an infarct. Then another example, female with high blood pressure had a car accident. She said that she didn't see the other car coming from one side. And the husband confirms recent visual problems. So what happened here? They did a examination, and here in the visual cortex area, in the occipital lobe, the area of the posterior cerebral artery, there was a stroke. So that's why the patient had contralateral homonymous hemianopia, a visual field loss on the other side, not the other eye, but on the other visual fields, always contralateral, and that's why she couldn't see the car coming from this side where she had visual loss. So in this case, the stroke led to a car accident. Then this is what you went through many times in many lectures already in the first semester when we learned the epidural bleeding with the middle meningeal artery. So you know these bleedings: epidural, subdural, subarachnoidal, and intracerebral. Here I just mentioned one example. It's typical in drunk people who sit on the bike going home from the pub. They fall. So this guy fell, short consciousness loss, and then later they regain consciousness, they go home, and then they collapse again and lose consciousness again. And then it turns out that he had epidural bleeding. It's especially misleading in drunk or drugged people because you don't know if they are unconscious because they just drank too much or because they have an epidural bleeding. And he wouldn't remember that he fell and hit his head. And this lucid interval, this clear interval is called lucid interval, when they gain consciousness and then they lose it. Again, this is typical for the epidural bleeding. And we did talk a lot about increased intracranial pressure and herniation. This is also something already mentioned in the first semester when we talked about the foramen magnum and parts of the tonsilla, the cerebellum, can be herniated there. But you don't have to know the others. I just wanted to show you that the foramen magnum herniation is not the only one. There are several other places where the brain can herniate. For example, the uncal herniation at the uncus part of the brain is a common one as well. Here is another example. An 18-year-old football player had an accident, became unconscious. A week later, he was okay and continued playing, but then lost consciousness again. And he had a subdural hematoma. And this subdural hematoma led some time later to diplopia, contralateral hemianopia. Why? Because there was increased pressure. There was an uncal herniation here, herniation of the brain because of the increased pressure. And the PCA, so posterior cerebral artery, was compressed. That's why he had contralateral hemianopia. And diplopia because of the compression of the oculomotor nerve, which we know is leaving the brain behind the posterior cerebral artery. So if you know the location, you can get it together with the symptoms very easily. In the last part, I would like to show you some brain tumors. You don't have to know the types of brain tumors, just to demonstrate how important all this, what you learn now, will be later. Of course, everybody heard about brain tumor, brain cancer, different brain tumors. Most what you will see as a doctor is metastasis, because many cancer types give metastasis in the brain. Lung, breast, colon, kidney, melanoma gives sometimes multiple metastases in the brain. And the brain tumors can be of neuronal or glial origin. Here I show you some names. You don't have to know these names, just to show you that from any glial cell that we listed, astrocytes, ependymal cells, oligodendrocytes, we can have these tumors, which can be benign or very malignant. Here are just some cases how big they can grow. They do not respect boundaries if they are malignant, and they grow through pathways, etc. Glioblastoma is again a death sentence if somebody has a glioblastoma, because it's very aggressive. It's one of the most aggressive tumors. In a few months, it grows huge and basically kills the patient. You can see these really ugly cases. So the symptoms, again, where is the tumor, and then what symptom will be because of its location. So, for example, what we do ask, so this is something you do have to know, the relation with the pituitary gland and the optic chiasm. This picture is again shown many times in the exam, a picture of the basal part of the brain for the blood vessels, mammillary body, optic chiasm, optic nerve, etc. So here, the optic chiasm, you know that below the optic chiasm, we have the pituitary fossa with the pituitary gland, where we have tumors. It's a very common tumor. It's a benign tumor of the pituitary gland, the adenoma. It's growing most of the times upwards, so it will compress the optic chiasm. And then you know which visual field loss we have when the optic chiasm is compressed. We have bitemporal homonymous, bitemporal hemianopia, bitemporal heteronymous, not homonymous, bitemporal hemianopia. So you just have to know this word, bitemporal hemianopia. So both temporal fields are lost because the crossing fibers will be first compressed. Craniopharyngioma is a type of pituitary tumor, mostly in children, because this tumor starts from the Rutgers pouch. You know, Rutgers pouch is the embryonic part of the pharynx wall where the pituitary gland anterior lobe begins to develop, and this pouch will disappear once the pituitary gland is formed. But if it does not disappear, then tumors can develop from it, and this is called craniopharyngioma. Then another tumor that you should know by name is the acoustic neuronoma, which is actually not acoustic and not a neuronoma most of the times, because it's a schwannoma. It's from the Schwann cells of the vestibular nerve, not the acoustic nerve. Acoustic neuronoma, here there are some cases shown. They can be quite big. Usually they are benign, but they compress a lot of things. First of all, what do they compress? Facial and vestibulocochlear nerves are in this angle, in the pontocerebellar angle. It can even grow in the internal acoustic meatus and compress, of course, mainly the vestibulocochlear nerve. So you have balance problems, dizziness, hearing problems, or you hear things that do not exist. This is called tinnitus when you hear noises, and the facial nerve palsy. And the last thing I want to show you is one case. Maybe I will be a couple of minutes longer. It's I would like to lead you through one case where we will see how the diagnosis is going. It will be a case of meningioma, which grows from the meninges, and it's usually benign from the arachnoid. Here you can see some cases. Oh, sorry, I'm not there yet. Just one second. Yeah, it's coming in 2 slides, sorry. So I will be a couple of minutes longer, but I think it's useful before the exam. So another thing we ask sometimes, so where is this meningioma? Where is this tumor? And then what will be compressed? So here you can see mesenchethalic lesion, where you learned this word Parino syndrome when you talked about the eye movements, and you know that in the mesencephalon you have the center for vertical eye movements. So of course, if that area is compressed, the patient has vertical eye movement problems. He cannot look up. He's looking up with the whole head. This is called Parino syndrome. And another very important area which you have to know is the cavernous sinus. These we always ask in the exam, cavernous sinus and its anastomosis, its connections. So cavernous sinus, it can be asked in these pictures as well. And we know that it has anastomosis with the superior ophthalmic vein and through the superior ophthalmic vein with the angular vein. And inferior ophthalmic vein has anastomosis with the pterygoid plexus. So actually, especially in this so-called death triangle, if there is an infection, infections can spread through the angular vein, superior ophthalmic vein, cavernous sinus, and then goes a cavernous sinus thrombosis. Here I show you 2 examples. This patient had eyelid plastic surgery, and the wound was infected, and then here you can see that there is a cavernous sinus thrombosis. Ophthalmoplegia means that the eye muscles, that are the nerves for the eye muscles are running in the cavernous sinus or in the wall of the cavernous sinus, and these will be affected or can be affected in a cavernous sinus thrombosis. Or another example, where in the history we find infected upper molar tooth, was extracted a few days earlier. So the infection spread from the pterygoid plexus through the inferior ophthalmic vein into the cavernous sinus. Here you can see a big cavernous sinus thrombosis with swollen eyes, swollen face, and total palsy, paralysis of the orbital muscles. And the last thing you should know by name, and I mention here, not the last thing you should know by name, but the last thing I mention by name is the Horner syndrome. Horner syndrome, you know, is when we have the sympathetic trunk on the neck compressed, and this leads to small pupil miosis, ptosis because of the tarsalis muscle, and enophthalmos, which is not so obvious, but these are the three symptoms. This woman had pain in the chest and upper limb, and by examining, it turned out at the end that she had a tumor in the lung. Here there was lung cancer in the apex of the lung, which has a name, Pancoast tumor. And why did she have chest and upper limb pain? Because it compressed the brachial plexus from underneath. And then when it reaches the apex is in the lower part of the neck anyway, in the scalennotracheal fossa, it can compress the sympathetic trunk. And this is the case I wanted to show you. I lead you through one case, a few minutes, to see how from the symptoms we get to the diagnosis. So here, this patient had epicritical loss in the left lower limb and horrible headache and epicritical loss. So then after examining, there was an MRI, and here you can see a big tumor. At this point, they didn't know yet that it was malignant or benign. It partially looks like a meningioma, but partially not, because it has this area. And then further examinations were done, like the perfusion of the area. It has very good blood supply. And you know that malignant tumors usually have a better blood supply than benign tumors. This was the cyst part of the tumor. Then they can do spectroscopy. With spectroscopy, you can see the metabolites in the brain. So, of course, you can imagine that there's a completely different metabolite pattern in an infection, in a malignant, or in a benign tumor. This spectroscopy showed that it was benign, just like the tensor imaging or tractography showed that it was benign, because again, malignant tumors do not respect any boundaries, they grow through tracts. Benign tumors compress the tracts to the side. So this is what we see here, all the tracts are around this thing, not through this thing. Then the symptoms, how do they get together with the motor and sensory homunculus? That is again something you will have to know. Lower limb on the medial side, then trunk, then upper limb and hand, and then face on the side. Just this much. You don't have to know exactly where the little finger is located, but just this, the main body parts, what I just listed. So here, this thing is compressing the motor and sensory areas of the brain. Motor symptoms were very minimal, but the sensory numbness of the lower limb, so of course, because it's on the medial side, motor and sensory, so medial side is compressed, so she had lower limb symptoms. And then they did, for the operation, they do angiography to see the blood vessels, how the blood vessels are running inside the brain. This is very important for before the operation to see, for the surgeon to see how the blood vessels are running. So this is what the neuroradiologist can see when they inject the contrast agent. They can see how the blood vessels are branching and how the blood from the arteries goes to the veins. So this is what they saw. This is the internal carotid artery in the canal, then the carotid siphon, then the anterior and the middle cerebral arteries. And here they could see that there was an empty space. This is the tumor. And if we go on with time, you can see that the blood goes to the capillaries, then to the veins. But this thing doesn't have any blood supply from the internal carotid artery. Here you can see that the sinuses are already visible, because this is what they see when they inject. They see how the blood flows from the artery to the venous side. So then they see this sagittal sinus, transverse sinus, sigmoid sinus, then the jugular vein. And from the side, you can see the same things. This thing does not have any blood supply. So at this point, it's already kind of suspected that this is not a brain tumor, but a tumor of the meninges, because it doesn't have any blood supply from the internal vessels. And here the surgeon had to see how these bridging veins are running. Bridging veins are the veins, superior cerebral veins that run directly into the superior sagittal sinus. And these bridging veins here, very well visible. This is what the surgeon has to really pay attention to. And then they did an angiography through the external carotid artery to see the blood supply of this area. And this is where they could see that this tumor gets the blood supply from the external carotid artery. And so they do know that this is a meningioma, middle meningeal artery. And here, this is the external carotid artery with the occipital, pharyngeal branches here, the maxillary, and this is the middle meningeal artery supplying this area. So this is how you can get closer and closer to diagnosis. And this is all I wanted to say today. I'm sorry for being too long, but I think before the exam, you didn't mind. And I wish you all a very good studying time for the rest. And I see you tomorrow for the closing lecture. If you have any questions, of course, I'm happy to answer.